Seminoma, that's the patient who's getting chemo. Which one is better, chemo or
All right.
radiation? But we cannot tell.
Right. So stage 2 disease. So that's stage 1. So stage 2 disease we divide into ABC, right? Less than 5, 5 to 10. So a case can be made in stage 1 disease. So anyway, in terms of volumes, so we talked about, oh, that's what we're talking about. Pelvic surveillance versus periodic versus dogleg. The latest, so you should be aware of that, is by Jason Estefatu from Harvard, in terms of evidence-based contouring guidelines for seminoma. You know that, do you?
Yeah.
Good.
Yeah.
So that's what that is. Soup border, etc. has come down. What am I going to say? Yeah, the left-right issue in terms of the width, more lateral on the left side, just because the drainage parallels the testicular vein. So on the left side it goes into the renal vein, right? Whereas on the right side it goes into the IVC. So the lateral extent of the CTV, on the left side has to be more lateral than on the right side.
Yeah.
Right. Okay. And the dose, whether it's 2515 or 20, having low dose, right? All kinds of things. In stage 2 patients, the 2A patients are the ones we would treat with radiation. I personally think they should also get chemotherapy, but if you're going to treat them with radiation, the issue then is dose and volume. From my perspective, if you have stage 2 disease, the way I used to treat it was I would assume that there was retrograde spread from involved disease to the pelvis, and I would treat both sides of the pelvis. That may have been unnecessarily large volumes, but I certainly think you have to treat the ipsilateral pelvis as retrograde spread. And dose-wise, you have 2 approaches. I used to do it as a concurrent boost, which is not with IMRT, obviously, at that time. But I used to put a field and prescribe 3,520 to a 2 centimeter margin around the gross disease, and put an attenuator in the rest of the volume. So while that was getting 35 and 20, the rest of the volume was getting 25 and 20.
Oh.
Right.
Yeah.
So, but
Now
it's much easier just to give a boost, or, sequentially, whichever, right? But you need to get 35 to 40 gray in there to that area. There was always an issue of historical interest because these patients who have stage 2 disease have a higher risk of relapsing above the diaphragm.
Okay.
And some issue of elective supraclavian radiation, electrical radiation, which is just of historical interest.
Yeah.
Except it shows, the disease hasn't changed. The disease will still spread there, but it's far better to salvage that with chemotherapy. I think you should have chemotherapy at the beginning. Salvage that with chemotherapy rather than compromise marrow, rather than give cell radiation, and all those issues. In more than stage 2A disease, there's no question you give chemotherapy. The issue is, okay, what do you do with the residual masses? Because seminoma is different from non-seminoma based on chemotherapy with residual masses. Because in non-seminoma, residual masses have to come out. They have to come out because they have a higher chance of having a tumor, and they have a fair probability, even if it's not a tumor, that it's mature teratoma, which can recur and kill the patient also. The mature teratomas are not necessarily a benign thing. That doesn't seem to happen in seminomas. I think it's interesting why it doesn't, but it doesn't as much. So the residual masses after seminoma, provided that they're less than 5 centimeters and they're not growing, we can just watch. You can just watch because often they don't do anything. They're just scar tissue. And if you just jump in there surgically, the tissues apparently, after treatment, and it's usually in the context of chemotherapy because it's usually bulky, so it was more than stage 2 disease, so it's usually bulkier, right? They get chemotherapy.
Yeah.
The tissues after chemotherapy for seminoma have far more of a desmoplastic response than in non-seminoma. I don't know why. And so the surgical morbidity is much more. So for those reasons, you don't charge off and do an RPL. Yeah, one other thing to think about is what about patients who present with, it's almost always present with brain mets. Because brain metastasis from non-seminoma or seminoma, or the equivalent in women with choreo usually, very curable disease. And the question is, manage the brain mets with radiotherapy, which you usually do. But because these are young people and you're wanting to minimize long-term toxicity, if you have 1 or 2 mets, just treating that with some focal technique and trying to minimize use of whole brain radiotherapy. But if you're using whole brain radiotherapy, not to treat it to not to use 20 gray in 5 or 30 gray in 10. But use 2 gray per fraction so you can give, so in the long term it's better tolerated.
20 and 10, something like that.
30 and 15, kind of, yeah. 20 and 10 is probably lymphoma.
Okay.
Yeah, so that's that. The issue of what do you do in follow-up. So the big thing in seminoma is surveillance. And what is your surveillance strategy? And essentially, the first 2 to 3 years is more intense with the imaging examination. We do markers, but markers, I have 1 patient in 30 years where the markers helped me with anything because it picked up a second testicular tumor.
Okay.
That's a lot of markers that I have to waste my ink signing because it's normal. But I throw in LDH. I think the most important marker is LDH. We do alpha pure beta ECG, but I think the LDH is the one that's more useful. And I make a decision as to, so they're all told about testicular self-examination. You examine the testicle. And annually I get a testicular ultrasound if in their original pathology there was intratubular germ cell dysplasia. If there was not, then I don't. But it's those patients who have, so in Scandinavian countries, in Denmark for instance, there's such a high risk of A, testicular cancer, and B, bilateral testicular cancer, that they actually used to, I don't know if they do now, bivalve the remaining testicle and do biopsies to see it. And if they did, they used to give low-dose radiation to prevent, but anyway, so from my perspective, what I do is that's how I decide as to whether or not
do ultrasound.
Huh?
Do ultrasound or not?
Yeah. Yeah, hi Olivia. Farmer, yeah. Isn't he on home hydration?
Here I am coming for computer services.
He does have a drop? Oh, okay. Really? Okay. So I'll ask Sam to come by and have a look at him. Okay, it'll be about 10 minutes. Okay.
South?
Well, where? Oh, it's in the usual, right? Okay, thanks. Bye. I've never been there. So what is this one? South or where we are normally?
This is south.